Okay, I think we'll kick things off. So welcome everybody to the TIA Centre Seminar Series. Today we're joined by Jana Lipkova, who's going to be presenting some of her great recent work. So Jana is a postdoc researcher working in computational pathology in the group led by Professor Faisal Mahmood at Harvard Medical School. So prior to that, she obtained her PhD in computer science, with a focus on neuro-oncology at UM. And of course, now she's working on computational pathology, working to achieve objective diagnosis, improve prognosis, and biomarker exploration. So for those who are joining for the first time, we treat this as an interactive seminar. So Jana's going to give a presentation, but if you have any questions, you can raise your hand or you can ask a question in the chat. So I think with that, it's great to have you here, Jana, and whenever you're ready, you can begin your presentation.
Thank you. I'm really happy to be here. I would just maybe ask you to shout when you have questions, because I may not always see you, but yes, please keep asking. Okay, so very good. So I will be speaking about cardiac allograft rejections, but maybe first a little bit of background. So maybe you know that heart failure is the leading cause of hospitalization in the US, also in Europe, and there are around 26 million cases of heart failures yearly in the whole world. And for the patients that are already in the end stage of the failure, heart transplant is often the only viable solution. And there are approximately 5,000 transplants performed yearly in the whole world. So it's not such a large data set. So this would be the transplant. And as it's the case with any solid organ transplantation, there is a high risk that the body will recognize that the new heart as a foreign object and try to reject it. And to prevent this, patients are treated with immunosuppressive medications, and the medication is tailored to the patient's specific conditions. But despite the medications, the patient can still undergo rejections, and it's also the main complication and the main cause of mortality for the patients with heart transplant. It affects approximately 40% of recipients, and depending on the type of the rejections, the patient medication is then adjusted. So that's the background. Now, how do we detect those rejections? So the sort of problem is that the rejections are asymptomatic, and therefore patients have to go receive the regular surveillance biopsies. And the gold standard is HNA stain biopsy, which is assessed manually. And the assessment includes following tasks. So there at the bottom, there is a sign-out sheet that I took from the hospital. But basically, the assessment tasks include detection of the rejection, subtyping of the rejection, where the rejection can be acute cellular or antibody-mediated rejection. And then also we have a grade which characterizes the severity of the rejection, and it ranges from 1, which is low grade, to 3, to high grade. Moreover, few of these rejections, they can also coexist at the same time. It means you can have a patient that have acute cellular rejection and antibody-mediated rejection. And there are also like a benign conditions that look like a rejection, but they are not rejections. And such example is QLTB lesions, and it's like a very known mimicker of the rejections, and is also reported in the sign-out sheet. So I'm not pathologist, and always when I meet a new disease, I like to have to understand what I'm looking at. So now I have like 2 slides about the crash course to look at the heart biopsies. So in the first column, you can see the normal tissue, and it looked like a muscle tissue. So this is healthy cardiac tissue, which look like a muscle tissue, since it's a muscle in some extent. And you can see this nice regular structure. In the case of rejection, the first type are these acute cellular rejections, and they are characterized by the presence of lymphocytes infiltrate inside the muscle tissue. So you can see different, on this, there are 3 examples showing different types of infiltrates. And usually these infiltrates, they have like a homogeneous structures and consist from T cells. Then we have antibody-mediated rejections, which are characterized by increased extracellular space, which is caused by edema. So this is what the red arrow is showing. You can see like this swelling between the tissue, muscle tissue. And another characteristic is like changes in the capillary, which is what is shown by the green arrow. And these are those QLTB lesions, which also consists from the mix of B cell, T cells, and they look pretty similar than the acute cellular rejection, especially if you look at the third column, but they are not treated. It's like, it's still abnormal finding, but doesn't lead to the changes in the treatment or patient management. But they look as a rejection, which is gonna be important. In the terms of grading, so the rejection grade is characterized by the extent of myocardial injury, and it ranges from 1, which would be the mild rejection, to 3, which is severe rejection. And in the case of cellular rejection, the grade 1 is defined by the presence of 1 focal injury. So there is this blob of lymphocytes you can see in the first figure. If there are more than 2 injuries, it's going to be grade 2. And if there are multiple injuries and a plus presence of other abnormalities like edema or like hemorrhage, it's going to be the grade 3. Basically, grade 3, it's a lot of stuff went wrong already. In the case of antibody-mediated rejection, it's also similar grading strategy. With the increasing amount of injury, the grade is also increasing. Maybe interesting fact is that antibody-mediated rejections were officially recognized only in 2011, so they're relatively new. Okay, so this is the grading. But even if the grading sounds to some extent quantitative because you're counting the injuries, it's highly qualitative because, for instance, if you look at this region, you can see there are like, are these 2 injuries that are like small, or is this 1 diffuse injuries? So it means there is a lot of space for subjectivity, which brings us back to our task. So we would like to look at the assessment of cardiac biopsies, but one of the main motivations, there is really large inter and intra-rater variability. There was a recent study that shows that less than 71% of cardiac experts agree if the patient is rejecting the heart, less than 28% agree on the grade of rejections, and in 19% of cases, they were not able to reach a majority agreement. And of course, like misinterpretation of the rejections has a lot of disadvantages. It can lead to under or over treatment with immunosuppressive medications, unnecessary follow-up biopsies, and can contribute to the overall worse outcome. Yes, I see a question.
Hi, Jana. So you mentioned that the Quilty B lesions, that they would be included on the sign-out sheet.
Yes.
So do you know why that is the case and why they're not just treated as a negative example?
So there are multiple reasons. One, because they really look like the rejection. So you want to like keep a track if this patient had the Quilty B lesion or not. The other, it's still abnormal finding, and there is like a lot of debate, and it's not really yet understood if it has some consequences or not. But at the moment, it's not treated, but it's not the normal condition, so it's still reported. Did it answer your question?
Right. Yeah. So that might be a direct cause of the transplant, but it's not completely understood.
Yes, exactly. It's not understood, and there are like a lot of papers. Some people claim it may have, some other not, but in the official guideline, it's not treated, but it's reported.
Great, thank you.
Okay. So because of all this large variability, we would like to, and also you can see that the task of assessment of the biopsies is maybe more complex compared to, I don't know, cancer detection, where just the presence of specific morphology will be sufficient to determine the diagnosis. Here it's like more complex. You can have different grades, you can have multiple rejection that coexist, you can have these different mimickers. So it's a bit more difficult. And we would like to overcome the problem with the large inter-rater variability. We would like to come this objective and automated assessment of the biopsies, as you expected. So to address this problem, we developed cardiac rejection assessment neural estimator solver, or CRANE in short. CRANE is it's a weakly supervised model that takes as an input H&E stain whole biopsy and simultaneously identify all major diagnostic tasks. It means for each slide, it identifies presence or absence of acute cell rejection, antibody-mediated rejection, and or Quilty B lesions. And for each rejection, it also estimates the grade. So from the implementation point, basically it's a multitask and multi-label approach. Multi-label because for each slide we assign multiple labels. Is there a cellular rejection? Is there antibody-mediated rejection? And multitask because it learns all the tasks simultaneously. And we use multiple instance learning, which allow us to train the model using the patient diagnosis as only label. It avoids all the need for pixel level annotation or feature extraction. And the motivation, of course, is because manual annotations are expensive, but also there is this large inter-rater variability, and you don't want to translate it to your model. So we want to just work with the patient level labels, and it also allows to scale the model to large data set. I will look into detail to the model. So the first step of the model, it's just high level, so just skip and ask questions whenever you want. So the first step is we take the whole slide image, we segment the tissue, and we divide the tissue into patches. Then we extract features from the patches. We use ResNet that was pre-trained on ImageNet to extract the patches from features from individual patches, and then we have like 3 fully connected layers to fine-tune the features a bit more. So now basically we have patch level embeddings, and we would like to, but we don't have patch level labels, as is the case with multiple instance learning. We only have patient level labels. So we would like to aggregate the information from the patches to obtain the slide level or patient level labels. And there are different ways how you can do this aggregation. You could like use max pooling, min pooling. What we use here is the attention-based pooling. Basically, we use 3 networks to learn something called attention score for each patch. And attention score basically, where's this A? The equations are just for the curious people. You don't have to follow those. Basically, the attention score, it reflects relative importance of each patch towards the model predictions for the given task. So basically, for each patch, we would have 3 attention scores, 1 per each task. And the attention module, which is shown here in the figure, consists of 2 layers. The first layer is learned jointly for all tasks, and then we have 1 separate layer for each specific task. So basically, this is how we learn the attention score for each patch and each task. And then to obtain the slide level embeddings, we use weighted average of the patch level embeddings, and we weight them with the corresponding attention score. Okay. Once we have the slide level embeddings, this is what is used as an input for the final classifier, which consists of 3 binary classifiers. Basically, for each patch, we want to predict is there solo rejection or not, is there antibody-mediated rejections or not. Okay. Yes. Go ahead.
Hi, Jana. So I guess from the equation for your attention score, you're for each, or for all patches within a single slide, you're getting a probabilities distribution. So what if for a single whole slide image, you don't expect there to be any positive region? So would that potentially reduce the interpretability of these whole slide image heat maps? How would you go about it?
Yes. So basically, it will predict like the negative label, yes. But so there is still interpretability, and it's gonna be like, I'll actually show you interpretability for the negative case. That's a good question.
Right, thank you.
Mm-hmm. Okay, so exactly, these are the attention heat maps. That was the motivation, that you can then visualize the attention heat maps to see which part of the biopsy were predictive for the given task. Okay, and then so this would be the rejection detection, and then to estimate the rejection grade, we train separate networks which for each rejection predict the grade. And the architecture is the same as for the cancer detection. I'm sorry, as for the cardiac rejection, but it's just a single task instead of multitask. And I told you there are 3 grades, but we divide them into 3 groups. So we just have a binary classifier that will predict if there is low versus high grade rejection, where low would be grade 1 and high it's a grade 2 or 3. And the reason why we combine grade 2 and 3 together is because the low grade rejection, they don't require usually any intervention. They are still just observed, but both high grade rejections, both 2 and 3, require some intervention and changes in medication. And the second reason is that the grade 3 rejections are extremely rare. We had like 9 cases since 2005. You cannot really try a whole slide level model, but they're very rare, and they are like, in the last 5 years, we had none of those. So it's not so common. Okay, that would be the model. And so now we look at the study. So this is our study design. We collected over like 7,000 whole slide images from 3 independent cohorts. And we designed the data sets in a way that they like deliberately express the large variability that exists in the histology data. So we have like a different population. Each data set were scanned with a different scanner. Each has like different micron per pixel, different noise, each center use. different slide preparation, different staining. So for instance, in Turkey, they use, so we have data from US, Turkey, and Swiss. And in the Turkey cohort, they use manual staining, while in the US and Swiss, they use automated staining, which is interesting because it really changed the variability of the images. And the motivation is that we're going to train only on the data from the US, and then we're going to test on the data from US, Turkey, and Swiss to see how well the model generalizes. And we don't do any domain specific adaptation. So we can like see really how the model generalizes despite all the changes. Or maybe here, like interesting note is the data from Switzerland, they were scanned at 20x, but the micron per pixel at their 20x magnification is comparable to 40x from Operio and Hamamatsu, which was, I never saw this before, but it's a lot of variation. Here is just small example to show the color distribution across the different cohorts. Yes, go ahead.
Sorry, just a question in line with what you showed in the previous slide. So would you read at a specific level or a specific MPP?
Yes, so we train the model actually, we do the specific level, but we match them by MPP. Okay, so I try like multiple combinations, and we found that like if the MPP is the closest across the cohorts, then the model performed the best. I think that was the most important, but the difference wasn't so big. I don't really know why the Swiss data has such a different micron per pixel. It's very puzzling, but they are sure it's 20x and.
Yeah, so NASA has just said online as well, he asked, was domain shift an issue because of all of this that you're seeing on the slide?
I'll show you. Domain shift is a pain. Yes.
I could ask a question. Is it possible to use the same slides in different scanners so you can get a direct comparison?
It would be absolutely fantastic, but the data in our each cohort, they scan the data in their specific center. So they were scanning Turkey and Switzerland. We did not rescan them, but there was this study by I think Campanella or someone, and they were doing just simple like a binary classifier, and they were looking how much the performance degraded if you scan the same slide with a different scanner, and it already lead to the drop in performance like 5%. And it was still the same slide, but just different scanner. So if you add like a different staining, different noise, I think it's gonna drop. Yeah, but it's interesting. Okay, so I use this figure just to express the different variability of the data. So here the angle is showing basically color or the hue, and the distance is showing the saturation. And I was telling you the data from Turkey, they were stained manually, and there is larger variation in the data, in the color distribution compared to Swiss and US data. And on the patches, you can see like visually that there is like large visual difference in the color distribution, among other stuff. So here we're looking at the performance and the shifts and everything. So the first row is showing AU seekers for each specific task. The second row is accuracy. In blue is the performance on the internal cohort, and orange and green is the external cohort. So for the rejection detection, the model reached AUC over 90. Also, it's very similar for the other task. But now, okay, if you look at the generalization to the external cohorts, of course, there is a drop in performance. But the good thing is we see that the performance is comparable on two very distinct cohorts, which means the model is able to generalize across differences in population and scanners and stuff like that. Another interesting fact is that the data from Turkey, they also include pediatric cases, which we don't have in the train set, and the model still was able to generalize also to pediatric cases despite having different morphology than the adults. So this would be the generalization. If we speak about like a drop or data set shift from the internal to external, there is a drop in performance around I think it was around 12%, the biggest one, which if you speak about clinical deployment, of course, it's a large drop, and you would like to, if you do any clinical application, you would like to fine tune the model with the local data. But you can look at this as a baseline performance in the absence of any stain normalization or fine tuning with the local data. Okay, that would be the performance. Then this is the more colorful part. So now we can look at the attention heat maps and try to interpret the model predictions. And we didn't use any manual annotation, but the model was able to identify the morphology which was specific for each task. So in each of these examples, the model plays high attention, which is basically shown in red. It would be like a high relevance to the tissue region, which has diagnostically relevant morphology, while the blue is shown a region that have benign or like non-rejection related morphology. So if now you can practice what you learned from your crash course on cardiac biopsies. So for instance, in the case of the cellular rejections, you can see this agglomeration of the lymphocyte infiltrates in the tissue. In the case of antibody-mediated rejection, which is the second row, you can see the swelling, which is shown by the green arrows. You can also see that the model is able to distinguish the cellular and rejections and cruelty lesions. So it provides some way to interpret the results. That would be the attention heat maps. You can also use the heat maps to look at the failure cases, which is maybe the more interesting part. So here we are looking at the worst cases from each cohort, worse in the sense that model predict them as a rejection with high confidence, while they are all non-rejections. And each column would be like data from each cohort. And the first block is the cellular rejections and the other is antibody-mediated rejections. I mean, that's what the model predicted, but in truth, they are all normal. And maybe if you look at this, I think you don't see my mouse. Do you see my mouse? So this would be the, okay, so this is basically how normally the slide would look for like if it would be predicted normal. I mean, it's predicted positive because of this small region. Actually, I'm sorry, I was confusing. These are all cases that the model predicted as a normal, but they are rejections. I'm sorry. So this is how the attention heat map would look for the normal case. It's like a lot of blue, but still the model is gonna place high attention to any atypical morphology. So like, for instance, here at the edges, there may be some like small infiltrates and the model may place higher attention, but otherwise it's like mainly blue. This was to your question. And what I was trying to show with this example is, so also these are all normal cases. Sorry, also these are all rejections and the model predict them as a normal. Still the model is placing high attentions to the region that have morphology specific for the rejection. It just means that the features were not sufficient to predict the rejection correctly, but the attention heat maps are like the attention, these regions have higher attention. Okay, a bit convoluted. I hope that makes sense. Okay, so what I was trying to say, this is the way the attention heat maps you can use to validate and interpret the model predictions, but there's also motivation. Maybe you can use them as an assisting tool to guide pathologies, and it's something I will be showing you soon. Before we make, just to advertise, we make a website where you can go and look at all these different attention heat maps and look at the data. So you could like look at the rejections, look at the slides and data and play around with attention heat maps. And the website basically show the whole slide, the attention heat maps. It shows you the predictions and also like confidence of each prediction, which is shown in on the left. Okay, that would be the demo. Now we would like to, the next step is basically, so we have the attention score, we have the accuracy, but the question is how useful the model is like in reality. So to assess this, we made like a, nice. Okay, I thought it was a question. So we would like to see how well the model perform like in clinical settings and how useful it is. And the first step is to compare the model performance against the pathologies. So we conducted the reader study, which include 5 cardiac pathologists. They all have over 10 years of experience. And we asked them to assess 150 biopsies that were selected from the external Turkey cohort. And they were all, they were all asked to assign diagnosis. Now, it's a little bit difficult to make a direct comparison between human reader and and the model, because basically each of these pathologies can be seen as a gold standard or like the true diagnosis, but there is large variability across the pathology. So in the first study, we did something else. Rather than doing like computing accuracy, we look at the Cohen kappa, which allows you to compute inter-observer agreement, also accounting for the chance. So basically, if kappa is 1, it's going to be perfect agreement. If kappa is 0, it means agreement by the chance, and if kappa is negative, it means there is no agreement. And in the first step, we computed agreement between all our 5 pathologies. So this is the subplot C, and I didn't know how to visualize it, but I'll explain. So each line corresponds to the agreement between 2 pathologies. So for example, 1 is agreement between pathologies 1 versus pathologies 2. Each colorful dot corresponds to 1 specific task. So this would be agreement. For instance, in blue, we can see agreement between 2 pathologies for the rejection detection. And the column would be like a mean agreement on the specific task. And so what so first we computed agreement between the pathologies, and we saw that the agreement between our pathologies was comparable to the agreement reported in the studies, which means that our pathologies are doing a good job and we can trust them. And then in the second step, we computed agreement between the model and each pathology. So this is the subplot D. And we can see 2 things. First, that the agreement between the model and pathologies is not inferior to the agreement between 2 pathologies. So you can use it as a way to say that the model predictions are not inferior to the pathology's predictions. And for instance, if you look at the rejection detection, which is the blue one, there the agreement between 2 pathologies was like his kappa like 0.53, which would be moderate agreement, but agreement between the model and pathologies was 0.63, which would be substantial agreement. So this is one way how we compare the model versus human without having like the true label. This is one study, but I guess everyone wants to have a true label. So in the next step, we wanted to look at the 2 things. One, we wanted to see what is really the benefit of using the model as assisting tool and how the model compare. So we made, to summarize, we made another reader study where we we recruited another 5 pathologies different than those before. And we asked them to assess the biopsies. Again, they were looking at the same 150 biopsies as in the previous case, but then these are different pathologies. But we used the assessment of the pathologies from the first reader study to make like a ground truth label based on their consensus. Okay, so in the second study, we wanted to see what is the added benefit of using the model as assisting tool, like how we can really deploy it in the clinical settings. And we divided pathologies into 2 groups. And in the first round, 1 group of pathologies was asked to make diagnosis using only the whole slide images. And the second group used the whole slide images with assistance of AI model. And the assistance was in the form of attention heat maps that was superimposed on the top of H&E slide. Basically, it was what I was showing you on the demo website. So you could see the whole slide and you can move the attention heat maps to see the predictive regions estimated by the model. And following the washout period, the pathologies in the specific groups, they switch. So those that use only whole slide images now use whole slide images and AI assistance. And we said that for all the tasks, okay, so what the plot is showing, we are looking at all specific tasks and we are looking at the accuracy of each specific rater. So each line would be one pathologist. And the first point, which is just the whole slide image, is the performance of each pathologist when they have only whole slide image. And the second point is when you have whole slide image and assistance from the AI model. And we saw that for all the pathologists and all the tasks, the accuracy of the predictions increase when the pathologists use the assistance from the model. And yes.
Yes, I was just going to ask, so this is really impressive, this plot here in particular. I was just wondering whether there's any difference in the sensitivity and specificity scores separately, because of course you don't want to necessarily potentially increase your AURC values, but then decrease your specificity given sensitivity.
Yes, actually, we didn't look at the sensitivity and specificity of the pathologist, just the accuracy, but it's a really good question. So the motivation was we wanted to see if it improves like a consensus between the pathologies, but it's, and this is the way how we measure it, since they all have higher accuracy, it means they agree more, all of them. So this would be like the way of decreasing inter-rater variability. But you're really right. I didn't look at it, but it's a very good point. Thank you. Great.
And then a follow-on question from Nasir. He starts by saying it's a slightly cheeky question. Is there a chance that the AI assistants may bias the pathologist's opinion?
So we wanted to take care of this, and we don't tell the pathologists the predictions from the model. We just give them the attention heat maps for the corresponding task. Because exactly, I was worried if we tell them this is cellular rejections, they would all just don't search for it. So it's only the attention heat maps, and the motivation is that it forces all the pathologists to look at the same predictive regions. And that's the only assistance that we did.
Great, thanks.
Can I ask a question? Isn't the best way to, well, sorry, isn't there an alternative way of judging, of or even of training your program by using the results, the actual results of the objective results following the transplant, and in the follow-up to the transplant, you can see how bad the rejection is and so on, and make other measurements and use those to train the program rather than the opinions of pathologists.
Yes, this is very, very good comment. So in general, like only objective label that you can have, it's a patient outcome, as you said, right? So you will have to follow the patient and see what happened. But also that's a little bit difficult because there are a lot of reasons that can lead to the rejections. So the patients they are followed, and for the patients we have like a multiple biopsies over time, but there can be a lot of changes because sometimes the patients, they don't take the medications and they get a rejection. Sometimes there are like other reasons and they may get rejection, they may not. So it's even hard to quantify the outcome, like, or to remove other factors from the final outcome, right? But in principle, yes, I think that's the only objective label. So what we did instead, we basically asked, so our labels came from the sign-out sheet. So they are assigned during the normal biopsy readouts by the pathologists. And for the external cohorts, we ask our pathologists to check all cases to make sure that we have like a consistent grading and consistent predictions, consistent labels. So, but yes, that's on one way it's a limitation. On the other hand, these deep learning models, if you have large data, they should be robust to small levels of noise. Like if there is like some cases that are labeled wrongly, the model should be still able to learn out of it. But it leaves a lot of space for discussion.
This is an especially interesting question given some of those kappa scores that you showed on a couple of slides ago, especially for the one, I think it may have been cellular, where the kappa score was it cellular? No, for antibody, it was quite a low agreement, wasn't it?
Okay, yeah.
Between the pathologists.
Yes. Okay, but here I have to tell you a lot of secrets. Okay, so the antibody-mediated rejections are a little bit tricky. So there is one issue that they were recognized much later. So many centers, they start officially grading them later. So the pathologists have like, they may have 10 years of experience, but the antibody-mediated rejections are officially out less than 10 years. So that's like one reason. The other reason to make the antibody-mediated rejection estimate for very low grade, you will need to have IHC stain data to make a conclusive statement. And we didn't give the pathologist the IHC. Also, the model didn't use the IHC. The motivation is that it's sometimes the IHC, I mean, it's expensive. And if it's just a very low grade and there is no suspicion for the rejection, it's not always performed. So there is also like a variability in the IHC. Sometimes it's there, sometimes it's not. So we didn't use IHC, but in like clinical practice, probably pathologists should use IHC. But overall, like all the reader studies show that also antibody-mediated rejections are much harder, and agreement also in between normal clinicians with IHC, it's lower compared to cellular rejections. So now I reveal the secrets, and everything. Okay.
So before you continue, that's okay. So going on to your analysis of the whole study image results. I also had a follow-on question. So you said that you displayed the whole study image attention heat maps. You said, could there potentially be bias when showing these attention heat maps?
If the heat maps are biased, or if the pathology is gonna.
So for example, you showed the whole study image with the heat maps on top of it. So of course, your model has predicted salient regions within that heat map. So would the pathologist potentially be biased towards diagnosing within those highly attended areas?
I don't know, because we don't tell them what is there. We just show them it's a high attention. We don't tell them if it's antibody-edited or cellular rejection. So there is still like space for the pathologist to make the diagnosis. And there is other thing is that these high attention regions, they are not like a segmentation of the predictive regions, right? They put high attention also to, oops, it wasn't smart. They put also high attentions to the regions that are like atypical tissue, or like, I was trying to.
Yeah, we're back on the demo now.
Yeah. Okay.
There we go.
Where is I stop? Okay. So the model basically plays high attentions also to regions that are maybe not necessary. This one is showing full rejection. Okay, I have just the good figures, but in principle, if you look at these whole slide images, like in the second column, there are multiple red spots, and it may be not all of them have rejection. There can be like injury, there can be like just some, I don't know, noise or other reasons that look different than the normal tissue. So the pathologist still have to make some like assumptions on its own. Well, in the terms of the model, the diagnosis came from the region with the highest attention, but maybe it's not so. I don't know if it's gonna be biased. That's a good question. I would say less than telling them what is the diagnosis.
Yeah.
But of course, yeah.
Great, thank you.
Can I ask a question on this slide, please?
Yeah, we have a question in the room.
Okay.
Should I unmute myself?
Okay, hey.
Come up here.
Let's go there.
Sorry, hey. So I've got a question on this slide. So I'm having a hard time understanding the heat maps, to be honest.
Okay,
so imagine the block B, right? So so my first question is, the heat maps that you're showing here, are these from the positive class or negative class? Positive class being the abnormal antibody.
It's the class that the model predicted, and then,
so the negative class.
Yes, it's a negative class, but still.
Then correct me if I'm wrong, but it seems that, so in the third row, seems that the features are similar to those that has the antibody in them, right? So it seems that actually model is predicting the right thing to me, or maybe the image quality.
So it means,
cannot realize if it's truly the antibody effect or.
Yeah. So it means, what I was trying to say is that the model is looking at the right region. It's looking at the antibody-mediated rejection regions, but it didn't make the correct diagnosis. It still thought this was healthy, but the attention score are like placed in the correct regions, which was the motivation to use it as an assisting tool for the pathologist. Okay,
so what I'm trying to get at is that, is there a chance that there are some noisy labels in your data set? I mean, have you had these samples rechecked by pathologists to if there was some noises in the training set?
So there's gonna be some noise in the training set because there is a large variability, but we like examine all of them like manually to make sure that our pathologists agree on those. That's I don't know if the old pathologists in the world would agree, but this is what our pathologists would agree. But it can also be like, you know, that these are like very small injuries, and it may be the features are not discriminative enough. I mean, of course, with the diagnosis, you could maybe just change the threshold and this would be predicted differently, but with the default threshold, these were not predicted as rejections.
Yeah, thanks.
Thank you.
Okay, to find where we were. Okay, so we're almost basically done. So here I was just showing that the assistance from the model should increase accuracy, and it also decrease the assessment time, which makes sense because if everyone is looking at the same regions and if everyone is shown where to look, then the assessment time is going to be smaller and accuracy higher. Okay, so basically this example was we are not trying to show that we are not trying to replace pathologists, but this is to see what is the potential of using the model together with a human in the loop as an assisting tool. And we are basically almost, I mean, this is my last slide. So basically, rather than summarizing everything what I did, I just wanted to show the flow of the study because it was, I think it was well-designed study and I would like to reuse it and maybe useful for others. So basically what we did, we first identified the problem of high inter-rater variability in assessing the biopsy rejections. Then we did a lot of data collection. That was, I will not complain there. And then we did all the label preparations where we also asked our pathologists to make sure that the labels are correct. Also, there are a lot of changes in the official guidelines for assessing the rejections and the grades over time. So we have to make sure everything was up to the latest guideline. Then we train the model. Then we look at these interpretability maps to make sure that at least the model is making predictions from reasonable biopsy regions. Then we tested it on the external cohorts to see what is the generalization performance. Then we look at a comparison with the humans. Then we look at the potential of using the model as assisting tool for the humans. Then we publish it. And like a future work would be, you would like to test the model on a larger data set from multiple hospitals, like to make it as a retrospective clinical trial on large data set, maybe also have a prospective trial to see how really the model deployment and usage can benefit the clinicians. And then maybe one day it's gonna make it to clinic. So basically to thank, this is everyone from our lab, and this is the page with the resources. And if you have more questions, you can just jump to it.
Great, thanks, Jana. That was a fantastic presentation. And thanks for answering all our questions directed at you.
Thank you, it was very nice.
Great, so we have some more questions, if that's okay.
Yeah, absolutely.
Great, so I appreciate you're not a pathologist, but you can answer a question on how dangerous it is to perform this biopsy procedure, because in my view, obviously it's a naive view, it seems quite a dangerous procedure getting a biopsy from the heart. It
is. I didn't even know you can biopsy heart initially. So yeah, actually you have to inject the biopsies made through the vein in the neck, and they inject it directly to the heart. And I mean, it's dangerous, much more than like other biopsies, but I mean, and the patient have to stay in hospital like maybe for 1 day. So it's not so easy. Yeah. So it would be like really good if you could, like our next work is to look, can we predict when the patient's gonna have rejection so we can optimize the schedule for the biopsy, because the biopsy are so not easy. Yeah.
Right. So you mentioned a bit about having this large scale trial. So would you directly apply what you've already developed, or would there be anything that you would like to change in your future model?
That's a very good question. So one thing is with I just jumped through the results, but the performance on the grade prediction is lower compared to other tasks. So there is something where maybe we would like more improvements. And I mean, it's on its own, it's a very difficult task because it's like you have to count down different injuries, you have to look at the larger context, and the grades are not like well defined. If it's more than 2 injuries, it's a grade 2, but it can also be grade 3. But so it's a difficult task, but this is the one where is largest space for the improvements. And the other thing is there is still a relatively big generalization gap, right, from internal to external cohort. I mean, I can phrase it nicely in the paper, but there is a gap, and for any clinical deployment, you would like to reduce it. But like a standards methods for like, I don't know, stain normalization and all these strategies that didn't help, or nothing that we try was robust enough to work across all the cohorts. So there's a lot of space for that.
Yeah. So when you trained so you had this ResNet encoder, right?
Yeah.
So you said you trained your fully connected layers, I think it was, to be able to apply to histology. So do you think potentially pre-training it on histology specific data might help to reduce that gap?
That's a very big question. I don't know. I was asking my advisor because it sounds very intuitive, but there were some studies, I mean, not for the heart rejections, but for the different, I think some cancer detection, where they showed that the ImageNet was better because there is like a large variability of the features compared to the features you get only from histology data. But maybe you want to do both, right? Maybe you could combine histology and features with the ImageNet features. Maybe you get something more out of it.
Exactly. And what about techniques like color augmentation? Did you
Oh
use that?
yeah, I try so many stuff, and it's like usually it looks so good, but then the model just ignore it. We try like a different color augmentation. We try like types of, like, I think it's called fast cut, where we try to change the appearance of the image from one data set to look like the data from another data set, like to change the distribution of the colors, noise. And visually it looks so convincing, but it doesn't help much with the performance. And it was very hard to find something that would work for both cohorts. So sometimes I get better performance on Turkey cohort, but not on the Swiss one. And then it started to be headache. And yeah.
Right. So another question from Nasir. He asked, is any of the data going to be made available as part of this project?
So not exactly, but we are willing to share it. So we will not upload everything on one website, but we are willing to share it for non-commercial purposes. So you can just let me know. We can transfer.
Okay, so I guess it's such a niche task, isn't it? I've not really seen it at all in the literature up until now.
Yeah, it's interesting. It's also very different than cancer, right?
Exactly. So a question from Tilak. He asked, is there any quantification of lymphocytes to determine the cellular rejection? Is it just a subjective evaluation by the pathologist? If so, there is a high chance of inter-observer variability.
There is indeed high chance for inter-observer variability. So yes, so the official guidelines, actually, that's what I told you. The grade 1 is presence of 1 injury, grade 2 is presence of 2 injuries, and grade 3 is 2 or more injuries, which is already headache. So there is also the official guidelines are really subjective, and it's not like based on counting of the lymphocytes, if that's what you are meaning. I'm probably not answering the rest, but maybe some additional quantification could help to unify the guidelines, but it's really hard because sometimes you can have one large injury and it's still going to be grade 1 versus two smaller injuries where they are close together, and now it's going to be grade 1 versus grade 2. Anyway, it's difficult. I don't know a good answer.
Yeah, definitely. So I had a flick through. So was that a question from you, David?
Is there any possibility of getting useful information from less invasive procedures?
I like your questions, David. You're on point. Yes, so that would be absolutely great if we can have non-invasive. There is something called AlloMap. It's a procedure where they try to estimate the rejections from the blood samples. But these all are still just in the development. They are not used in any hospital. But exactly, if you could have some non-invasive, that would be great. So the short answer is none of them is approved yet to be used in a hospital, but they are being developed.
I saw you mention about, so in your paper, you mentioned future work could involve combining, for example, echocardiogram data and other forms of data along with your histology. Have you thought about trying to go down that route? Because that would be really interesting.
That would be really good. Also, it may help you maybe to get more objective labels, but none of those were performed. They are not even yet performed in our hospital. So if I would have those data, I would play a lot with them, but we don't have them.
Yeah, of course. Are there any questions? Yeah. Okay, I think we've asked you enough questions. So I think with that, we'd like to thank you again, Jana.
Thank you very much. It was great.
And congrats again on your work. It's fantastic.
Thank you. Thank you for good suggestions and feedbacks. Have a good day.
See you.